Hello my friends, a very warm welcome to this talk. My name is Dr. Saeed Kazmi, and today this is going to be a short video about a very common problem these days, and that is known as laryngotracheobronchitis, or in very simple words, croup. Now croup is a viral illness and it is considered to be one of the commonest causes of stridor in children. And stridor is a hoarse inspiratory noise which is created when there is narrowing at the level of the larynx and upper trachea. Now usually it occurs in kids which are aged 6 months to 3 years, but sometimes it can occur in older children as well, and it is quite notorious for reoccurring again and again, especially in autumn and winter months. Now as far as the etiology is concerned, it's a viral illness, so almost any virus can cause croup in susceptible children. But most of the times these are adenoviruses and para-influenza viruses which actually cause croup. Now the history is typically that these kids are usually coryzal for a few days, so 1 to 2 or 3 days history of mild fever, runny nose, nasal congestion, tickly sensation in the throat, and then all of a sudden they start to have an acute barking cough. So this cough usually occurs in spasms. So there's a coughing fit, and this cough has got a typical characteristic barking nature to it. So it's also known as the seal bark cough. So if you have watched National Geographic or any other animal channels, and if you have heard a seal barking, so this cough is very much resembling that bark of the seal. So that's why it's known as the seal bark cough. It doesn't happen in any other illness. It only happens when you've got narrowing at the level of the larynx and upper trachea, and it is the characteristic hallmark of acute laryngotracheobronchitis or viral croup. Now these kids are usually well. They're usually well, but sometimes they can deteriorate very rapidly, especially if the swelling in the trachea progresses. Then they can have increased work of breathing. Their sets may drop, and obviously then they need to come in. Now usually there is a subset of these kids with croup who usually have got repeated episodes of croup, and these are the kids who have got what we call as spasmodic croup. So croup basically is of two types: viral croup, which is usually associated with a viral illness, and spasmodic croup. In spasmodic croup there is usually no preceding events like a fever, cough, cold-like symptoms. These are the kids who were sleeping well, and all of a sudden in the middle of the night, either in the late evening or in the middle of the night, they would wake up with severe barking, cough fits, and they would be struggling to breathe, and usually the parents, they become terrified because the child has suddenly woken up from the sleep. And usually these are the kids who are late night visitors to the emergency departments or hospitals. These kids might also have sometimes an element of atopy as well, and some of them might have a history of viral wheeze or asthma as well. But nevertheless, it's very easy to differentiate between viral croup and spasmodic croup. So viral croup would be having mild fever and some of the other cardinal features of a viral URI, while spasmodic croup are absolutely fine. All of a sudden they wake up with a barking cough, or that might even culminate in stridor. Now as far as these kids are concerned, I told you that most of them are not that much ill. But if a child who looks very toxic along with a barking seal cough, has got a very high temperature, let's say 40-41 degrees Celsius, has got a poor cap refill time, and doesn't look very well on the general outlook, then in that particular case you should be thinking of bacterial tracheitis, and that subset of group, that subset of the patients actually would need IV antibiotics, because this condition, if untreated, can be fatal. Now coming down to the investigation, now viral croup is a clinical diagnosis. You don't need any type of imaging for it. But the thing is that the only thing that we usually recommend is pulse oximetry, and that also if the child tolerates, because if you upset these kids, the more they cry, the more harsh the stridor becomes. So the stridor can increase in severity when they become upset. So that's why it's very important that you minimally handle these patients. So do not make them upset. So if they are tolerating the O2 SAT probe, obviously you can check SATs, that gives you an extra assurance. But obviously if the SATs are less than 92% on room air, then they need to be given oxygen. Now, as far as the treatment is concerned, that the treatment for those kids who can take oral medication, they are not vomiting, the best medication is
Dexamethasone. So dexamethasone
alone in a dose of 0.15 milligram per kg. Usually this is the pre-hospital dose, and if they are being brought by the paramedics, they usually give this dosage to the kids. But let's say if they have not improved with this first dose of 0.15 milligram per kg body weight, then it can be repeated. So you can go up to 0.3 milligram per kg body weight. If they cannot tolerate oral medication, then intramuscular dexamethasone can also be given in a dose of 0.6 milligram per kg body weight. So majority of the cases would respond to dexamethasone. One single dose of dexamethasone is more than enough in majority of the cases. Sometimes they don't respond. So if that is the case, then the alternative could be to give them a 2 milligram budesonide nebulization. So 2 milligram of budesonide is taken, which is basically a steroid, and you give them through a nebulizer. If they improve with that, well and good. If not, then we go on to the third step, and that is adrenaline. Now, adrenaline works in most of the cases, especially if the stridor at rest and child is struggling to breathe. Then adrenaline in a dose of 400 micrograms per kg body weight, going to a maximum of 5 milligram. Okay, so you can start with 400 milligram per kg body weight, but you cannot go more than 5. So 5 milligram would be the maximum dosage. And this is the ordinary adrenaline 1 by 1000, which is taken. It is put into the nebulizer, and the child is given that nebulizer. Most of the time the kids, they improve with this adrenaline. Now it's very important that those kids who had adrenaline, they should be monitored for at least 3 to 4 hours, because sometimes they can have rebound. Usually they respond to adrenaline, but then they can have rebound symptomatology. The stridor can return. So once you have given them adrenaline, they need to be kept in and observed for at least 3 to 4 hours. Within 3 to 4 hours, if the symptoms they don't return and they're fine, they can be discharged home. If they need or if they deteriorate, then they would need another dose of neb, and then you have to give another dose of neb if they deteriorated within that 3 to 4 hours window. And if they need a second dose of adrenaline, then in that particular case you should keep the anesthetist on standby, because sometimes if they need a third dose or something, then there might be a danger of impending laryngeal closure, and then that's why the anesthetist should be on standby. In case you need them, then the child would need to be intubated. So for one dose of adrenaline, the child needs to be observed for 3 to 4 hours. So if there is a rebound phenomena, then you will give another one, and then you will keep these anesthetists on standby. If they have improved, you will discharge them. But I told you that a subset of these kids would come back again most of the times in autumn and winter month, because they have got spasmodic croup. So spasmodic croup is treated the same way as is a viral croup. Again, most of the cases would be treated with oral dexamethasone. If not, then you've got a choice. You can give intramuscular dexamethasone, or you can give nebulized budesonide, followed by, if needed, nebulized adrenaline. So this was a short video lecture about acute laryngotracheobronchitis known as croup. I hope you have gained something from this lecture. Please share it with your friends, and if you haven't subscribed to my channel so far, then what are you waiting for? Do subscribe and hit that bell notification icon, so whenever I upload a new video, you are always on board with me. So have a very good day. Take care. Bye bye.